Hello all, I am Dr. Pradeep Daniel from the Department of Pediatric and Preventive Dentistry. I am an Associate Professor from Vinayagam Mission, Sankaracharya Dental College. Today I will be talking to you regarding the management of children with special healthcare needs. This is a two-part seminar. I will be starting with part 1. So these are the contents of my seminar. So we will be covering on the definition, the classification of handicapping conditions, the physically handicapping condition, namely the physically challenged children, visually impaired, hearing impaired, spina bifida, and coming to mentally handicapped conditions, we have MR, learning disorders, childhood autism, and conclusion and references. So today we will be talking on the part 1 of it, which includes up to the physically challenging conditions. So first of all, we need to know what is a disability. So disability is a consequence of an impairment that may be physical, cognitive, mental, sensory, emotional, developmental, or some combination of these. So a disability may be present from birth or occur during any time during the person's lifetime. So an impairment is a problem in a bodily function or structure, an activity limitation, that is difficulty encountered by an individual in executing a task or an action. While a participation restriction is a problem experienced by an individual in involvement in life situations, thus disability is a complex phenomenon reflecting the interaction between the features of a person's body and features in a society in which he or she liveth. So coming on to definition of your handicapping conditions. So WHO in 1980 defined a handicapped person as one who over an appreciable period of time is prevented by physical or mental conditions from full participation in the normal activities of their age groups, including social, recreational, educational, and vocational nature. AAPD in 1996 said that a person should be considered dentally handicapped if there is pain, infection, lack of functional dentition that affects him or her as follows. That is, restricted consumption of diet adequate to support growth and energy need, delays or otherwise alters growth and development, and inhibits performance of any major life activity including working, learning, communication, and recreation. So coming on to the classification of handicapping conditions, so we can classify your handicap condition into 3 basic types, that is physically challenged, mentally challenged, and medically compromised. We have a few other classifications that go in depth. So Frank and Winter in 1975, they classified these conditions as blind or partially sighted, deaf or partially deaf, educationally subnormal, epileptic, maladjusted, physically handicapped, defective in speech, and senile. We have a few other classifications, one given by Agarholm in 1975. He classified into 2 basic types, that is intrinsic, which cannot be seen outside, and extrinsic, which can be exhibited outside. Nowak in 1976, he gave the classification as follows: physically handicapped conditions, for example like poliomyelitis; mentally handicapped condition, for example mental retardation; congenital defects, for example congenital heart diseases; convulsive disorders, for example epilepsy; communication disorder, for example deafness and blindness; and systemic disorders, for example hypothyroidism, hemophilia; and metabolic disorders like juvenile diabetes, osseous disorder like rickets, and malignant disorder like leukemia. So coming on to the physically and mentally handicapped children. So what basically constitutes a physically handicapped condition is hearing and speech defects, visually impaired, physically challenged, and spina bifida. These are the conditions which can be categorized into physically handicapping conditions. So mental retardation, childhood autism, Down syndrome, learning disorders are few of the conditions which can be classified into mentally handicapping conditions. So we'll be moving on to physically challenged children. So coming on to physically challenged children, the oral manifestation on these children include periodontal diseases, trauma to the anterior teeth, dental caries, bruxism, gingivitis, poor oral hygiene, difficulty in swallowing, and malocclusions. So what is the pediatric significance when it comes to these patients is they require shorter appointments. You should stress the importance of tooth brushing procedures. They should have regular dental reviews, and preference is given for fixed appliance therapy. Moving on to visual impairment. So visual impairment is a condition where the child has lost his sense of sight. So there are many causes for it. So prenatal causes includes optic atrophy, microphthalmos, tumors, cataracts, toxoplasmosis, or infections like rubella, syphilis, meningitis, tuberculosis, etc. Postnatal causes include trauma, hypertension, premature birth, hemorrhagic disorders, or infections like leukemia, diabetes mellitus, glaucoma, etc. So what are all the possible oral manifestations of this condition? They are prolonged immature swallowing pattern, reluctance to consume solid foods, poor oral hygiene, hypoplastic teeth, frequent trauma to anterior teeth, and increased gingival inflammation. So the pediatric significance when coming to dealing with these patients, dentists must attempt to describe the procedures vividly and accurately. Care should be taken to minimize noise as they are hypersensitive in all other senses. Describing the operatory equipment and dental chair should be a must. Child should be allowed to touch the instrument before they enter the mouth, and dentists can make use of touch, taste and smell rather than tell, show, do. So dentists should also be aware that the postural changes of sudden nature is very disturbing to these children. So we should avoid using any signs or expressions of pity and references to blindness as an affliction. So as said earlier, changes to the chair position should be informed. The oral hygiene should be explained and the child is guided through the procedures by the dentist along with the use of audio cassettes or braille pamphlets. Pharmacological behavior management is used if all other techniques fail. So when the dentist is in the operatory, any exit or entrance should be informed to the patient. Preferably only one dentist should attend to these children, and the atmosphere should be maintained in a relaxed state. For making the physical access of the patient easy, we should keep the passages free of any clutter. There should be no loose rugs and there should be no hanging plants. Coming to the condition of the dental operatory, we should ensure that there is a clear passage to the chair from the operatory before the patient arrives into the operatory. So move the operator and assistant chairs, hoses for handpiece, suction, air, foot pedals, bracket tray and any X-ray equipment away from the pathway. All areas should be well lit and the furniture should not have any sharp edges. Door frames and handles and edges of the steps should be well defined in contrasting colors to prevent any accidents. So contrast colors are also important to differentiate the walls from the floor. Handrails on staircases with steps that are not too steep are important, and tactile and braille maps can be posted on the hallways and elevators. Coming to glaring make the situation difficult for children as in the form of high intensity lighting, sun shining directly through the windows and highly polished floors. Use of large print signs with contrast colors for words against the background is indicated for partially blind children, and general principles can aid communication and comfort in dental setting. For example, a handshake on meeting, guiding the person through the practice by allowing them to take hold of your elbow rather than by taking them yourself. We should speak directly to the patient and not to the person who accompanies the patient, but if necessary you can also include the caregiver. We should avoid speaking to adults as if they are children. If necessary, we can repeat the instructions. So we should keep the instructions simple, stick to one topic or ask one question at a time in order to avoid confusion, and in guiding the patient to the operatory, ask if the patient desires any assistance. We should never grab, stop or move the patient without giving any verbal warning. We should also encourage the parent to accompany blind children. When speaking to an individual, we should always make sure that we face them and ensure that there is no strong backlighting as shown in the picture, as it interferes with the residual vision. We should always keep them informed of each step of the procedure, especially when there is about to be a sudden noise or sensation, and try to describe the procedures in terms of how they will sound, feel, taste and smell. We should always give the patient an adequate description before performing the treatment procedures. When making physical contact, do so reassuringly. Holding the patient hand often promotes relaxation. Allow the patient to ask questions about the course of the treatment and answer them, keeping in mind that the patient is highly individual, sensitive and responsive. Allow the patient who wears eyeglasses to keep them on for protection and security. It also helps certain patients who are photophobic. And to avoid any confusion, ask the parents about the photosensitivity. Describe the dental instruments and objects that is to be placed in the patient's mouth, and if necessary, demonstrate it on a rubber cap or on the patient's fingernail. Since strong taste may be rejected, use smaller quantities of dental materials with such characteristics. For example, eugenol is such a material, so little amounts of that material can be used. Explain the procedure of oral hygiene and then place the patient's hand over yours as you slowly but deliberately guide the toothbrush. There may also be a need to adapt oral hygiene instruction methods with the use of models and other aids. Causes of visual impairment do have an impact on the dental care. For example, diazepam and atropine need to be avoided in patients with glaucoma. Coming to management, ATP technique for teaching toothbrushing. So children were verbally informed about the importance of the teeth and method of brushing. This is the audio part, that is EA. Children were made to feel the teeth on a large size model, that is the tactile part of it, that is T. Then they are trained to brush on a model with assistance, that is the performance part of it, that is P, and then they are asked to do the same on their own teeth. Moving on to the behavior management. So touch, taste and smell can be used to handle these children. Explanation can be done by making use of the touching and hearing part of it. Reinforcement can be done using smelling and tasting, and listening, touching, tasting and smelling are important for learning coping behavior, and modeling can also be done by making use of their siblings. So moving on to hearing impairment. So hearing impairment is where the child has lost his sense of hearing. So there are many etiological factors for it. So the prenatal causes for it include viral infections like rubella and influenza, ototoxic drugs, congenital syphilis, and it may also be due to hereditary pattern. Perinatal causes includes toxemia, late in pregnancy, birth injuries, prematurity, erythroblastosis fetalis, anorexia, etc. And we also have a few postnatal causes which include injuries, ototoxic drugs like streptomycin, kanamycin and aspirin, viral infections like measles, mumps, chickenpox, influenza, meningitis and poliomyelitis can also cause this condition. So the pediatric significance. So treatment should proceed slowly, explaining at each step what is to be done. Proceed slowly in a reassuring manner using facial expressions, smiles, gestures, physical contact and praise. Speak facing the patient in a normal tone without using any slangs. Adjust the hearing aid while using the handpiece, as all sounds may be amplified. So a dentist should position his face towards the light so that he can be seen clearly. We should also minimize background noise, distractions and interruptions. We should allow extra time for the patient to respond, and if what you say is not understood, do not keep repeating it. Try saying it in a different way instead. We should also speak clearly but not too slowly, and we should never exaggerate our lip movements, and we should use natural facial expressions and gestures. We should avoid jargons and unfamiliar abbreviations. And when dealing with these patients, we should also resist the urge to shout. It will never help, as it is uncomfortable for the hearing aid user and it also looks aggressive. We should lower the pitch of voice. It is more effective than raising the pitch, as people tend to lose their high pitch hearing first. Use of gestures for visual feedback like thumbs up for you are doing well will help a patient through the procedure. Check that the person you are talking to can follow you, and be patient and take time to communicate properly. So before talking to the patient, we should make sure that the hearing aids are on. So many deaf children are lip speakers, so we should always talk to them in proper way. If necessary, British Sign Language speakers can be used. So British Sign Language uses manual and non-manual components such as hand shapes, movements, facial expression and shoulder movement, and the interpreter can be met before the appointment. So when dealing with these children, we should avoid the use of mask, as the child may attempt to read the lips of the dentist. Reassure the patient with physical contact like holding the child's hands, and visual aids will also be very helpful. Use of tell, show, do, positive reinforcement, modeling, behavior modification techniques are very helpful. Pre-treatment sedation, general anesthesia may be required for more serious behavior management problems. So coming to behavior management, so as said earlier, tell, show, do can be done. Positive reinforcement and modeling, all these procedures can help the patient cope up with the procedure. Moving on to the last part of this seminar, spina bifida. In Latin, spina bifida means split spine. So it is a birth defect caused by incomplete closure of one or more vertebral arches of the spine, resulting in malformations in the spinal cord. So some people may have little to no disability, other people may be limited in a way that they move or function. Some people may also be paralyzed or unable to walk or move parts of their body. So the possible oral manifestation of this condition includes poor oral hygiene with dental caries, periodontal diseases. So the pediatric significance of this disease is most of these patients have latex allergy, and pharmacological methods may be necessary to provide the dental care. I would like to conclude the first part of this seminar by saying that special children need special requirements before, during and after the treatment procedure, and the success in their care hinges greatly on the pediatric dentist patients and ability to empathize, ensuring the child's emotional well-being remains intact throughout the process. Physically challenged children that we discussed this time typically exhibit normal emotional development and can comprehend and adhere to the instructions provided. So these are my references for the seminar. Thank you.